I'm Donaldson. I'm affiliated mainly with Glasgow Caledonian University, but also have a part-time appointment here at ANU. I just wanted to say that given that I work remotely with the team, just to reiterate what I said earlier, how fantastic it is to have this team physically present in the room today, along with our distinguished guests. It really is a privilege to be here. Another aspect about working remotely is I don't feel as though I'm the main contributor to Work Package 10. There are other members of the team, some of whom are in the room today, particularly Elizabeth, who are the main drivers. But I'm more than happy to present the work that we've designed and applied together. So we're going to jump back to discrete choice experiments, but not here as a basis of deriving a health state utility values system. Here it's more about saying, well, once we have that QALY, how might the value attached to that QALY vary according to how the QALY gains themselves are generated, but also according to who the beneficiaries of those QALYs might be. So I think it follows on really neatly from Marcus's presentation and the discussion that ensued. So we're thinking here about, in a sense, the quantitative side of valuing a QALY, and we're going to explore it via trade-offs that respondents are willing to make across a set of predefined attributes, which we'll go into. So the extent to what we're exploring is the extent to which QALY gains from treating children and young people might be valued differently relative to other groups in societal healthcare decision making. It builds on previous work, which I'll also go into, but here we're exploiting a sample of young people in addition to adults, as is traditionally the case in these types of survey, of which I'll report. The usual attributes that are used in these types of study are the QALY gain itself, or health gain, as expressed in quality adjusted life years. The type of gain, by type of gain I mean how these QALYs are generated. Are they generated through improvements in health-related quality of life alone, or does it come via some aspect of life extension, or is it some mixture of the two? And then other conventional attributes that we look at in these studies are age of beneficiary, quality of life and life expectancy without treatment, in a sense, to get an idea of severity. But here we're adding a wider range of age groups, given the nature of this particular project, TORCH overall. And also, just incidentally, given the last point that was made in the last session, we are looking at the potential, quite crudely in this study, but the potential for including variables on educational participation and impact on carers. The theory behind what we're doing, I suppose, comes from, you might think of a fair innings hypothesis. So for those of you less familiar with what that is, it's the idea that a lot of people have in mind what they would see as a fair innings in terms of the number of healthy years of life that people might be expected to live, and anything beyond that, in a sense, any gains that people get once they've gone beyond notions of a fair innings are valued less. That's more a case for putting less weight or value on health gains for older people, but here, again, given the nature of the project, and an emphasis at the other end of the age spectrum, we're probably taking more of a life course perspective, but we haven't quite resolved theoretically what we mean by that. But that life course perspective, I think, also leads us to think about educational participation and impact on carers, so to a broader societal approach to evaluation. So taking that kind of rather fuzzy background and putting it into some specific research questions, what we're addressing through Work Package 10 is what are the preferences and preference-based relative weights for QALY gains, beneficiary age, severity, and type of QALY gain. Should QALY gains generated for children and young people be valued differently to those for adults, and what are the social preferences for potential what we've called spillover benefits accruing to the beneficiaries from the beneficiaries' own educational participation or the lives of their impacts on the lives of their caregivers. So the previous work on which the TORCH DCE study in the context of value and QALY rests is based on is this values and priority setting, or VIP study, that again many of us in the room were involved with, was led by Emily, of course, using stated preference methods to model general population preferences over treatment options and relative weights for QALYs. So it was an online survey building on previous, or what we have is an online survey building on the previous work of VIP, plus, as I've said already, a wider range of age groups, beneficiaries' own education now or in the future, improvement in the lives of their carers, and comparing values derived from an adult sample, as is traditional, to a sample of young people, 15 to 17-year-olds in the Australian population. As with VIP, we worked with animated videos and avatar-narrated backgrounds embedded into the survey presentation to explain to respondents its purpose, the attributes that we're wanting to think about and express preferences over, and basically in that to guide the respondents through the DCE task. A set of post-DCE questions were also included about usual things that you'd expect: task difficulty, clarity, normative reasons for age group prioritization, and social demographics. And there was a small amount of pre-testing by, I think, allowed interviews with adults and young children. So, what did each respondent do? They completed an example task, what we would call a dominant task, which is in a sense a test of their understanding. But from the data derived then from a subsequent set of 10 hypothetical choice scenarios that each respondent has to go through. They're presented with a choice between two treatments, A and B. I'll show you more detail on that in a second. But the lead up to that question is to say, below are two treatments for people with medical conditions. Given that only one treatment can be funded, which treatment would you choose to fund so it's available to you and to all Australians? So very much a kind of a societal or public perspective. Each treatment was described by 5 usual attributes of QALY gain, type of QALY gain, age, quality of life without treatment, life expectancy without treatment, but also we added these 2 additional variables to capture, as I say, what we've called spillover effect. So improvement to carers' lives if the treatment is funded, and persons receiving the treatment are more able to participate in education now or in the future. Here's an example of one of the 10 questions that a respondent might be faced with. So you can see in blue, I think it is, down the left-hand side, that's each of the main attributes. And of course then within each of the scenarios, treatment A or treatment B are different levels of these attributes. And the respondent is then asked to either fund this or fund this by placing the cursor and pressing a button. Of course, you'll see that some of the levels of the scenarios are equal across the 2 treatments over which this respondent is making a choice here, but there are a couple where they're different. So the idea is we can see for individuals, and then obviously more relevantly at the population level, the trade-offs that people are making across the attributes and across the levels. These are the 7 attributes, again listed down the left-hand side as you look at that page. Again, our 5 usual variables, and the 2 in blue at the bottom are what are different compared to the original VIP study. So that's improvement in carers' lives and the educational attributes as well. On the right-hand side, as you look at it, you can see the levels for each of these attributes that were used in the survey, and again, in black are the levels of those attributes that we used in the VIP study, and in blue are the new levels that have been added. So you can see, obviously, new attributes all have all new levels, but there are new levels now in terms of a more nuanced age attribute there at the top. And at both ends of the life course, if you like. Which is what I've just said. We used an online panel provider, Pure Profile, to give us a sample representative of the Australian population in age and gender. And they provided us with 2 online DCE surveys with just over 500 people from in the adult and the young people samples. Data were collected early part of 2023, with taking a little bit longer to recruit the young person sample. Right, so due to the nature of the data, we're into sort of what's called multinomial logit land, or that's what the MNL initials stand for. So what we're trying to do here is explore utility derived from each attribute level within our samples, but utility is obviously not directly expressed. It's expressed by quite a crude variable of yes or no response. So that's in a sense the basis of that's our dependent variable, which is really quite limited. And also many of the dependent variables are categorical as well. There's not necessarily any natural order as to how each of those might actually drive utility. So that's what takes us into MNL, multinomial logic, as being the best approach to use here. So I rest my case for multinomial logic here, and I'm not willing to take any more questions unless I have my solicitor present. But luckily my solicitor Elizabeth is present, so feel free to ask questions afterwards about multinomial logic. If you look sort of getting towards the second main bullet there in terms of what we call utility specification, that's just to outline that to better reflect theory and ensure a better fit for some variables, they are actually transformed. So for instance, QALY gains are logged just to reflect the fact that in a sense there's diminishing marginal utility, if you like, associated with additional QALY gains. So it's not a straight proportional direct relationship. So that's how QALY gains tend to be modelled in these types of study. As I've said already, all the other variables tend to be categorical, so they are dummy coded, and we've looked at a couple of interactions: age with carer and age with education. So that's the regression analysis, if you like. The last bullet there indicates the weighting exercise, which in a sense is where we want to get to. So how to explain that? So for each attribute, what we define is what we would call a reference case, or a PEG, if you like. And we set the midpoint of that particular attribute as equal to 1. So in a sense, it's what you might say is a normalization process, whereby from that we then calculate the compensation required or given up to move from the reference case to a less or a more preferred situation. And then all that data are then rescaled to ensure that there are no negative values. So that's the basis of the the weighting exercise, and we'll show you some data on those weights shortly. These are the sample statistics. Well, it's not much to say about this, except that by definition we have a population representative by age and gender, because that's what we asked the panel provider to give us. I'll just leave you to reflect on the other variables within the adult sample and the young person sample. I suspect it's a slightly kind of privileged sample that we have. And then the last bullet in under each of adult and young person sample shows that we have the groups had a fairly good understanding of what it was that they were thinking about. But there are other variables to reflect that, and other variables, as I said, to reflect how difficult or easy they thought the exercise was. In terms of preference results, so these are the sort of basic results from the basic regression analysis that I talked about. Common across both samples, children, teens and young adults were prioritised over older adults. There's a preference for treatments that increase participation in education and improved carer well-being. There's a significant age by education spillover interaction. So I think that's more weighted towards the value that we put on age is enhanced if amongst younger people if they're participating in, better able to participate in education. Preference for treatments that generated larger health gain, that's, again, you'd expect that, more QALYs, more utility, particularly where that gain was of the mixture sort in both life expectancy and quality of life together. And there's a preference for treatments targeted at those in higher severity. Where the two samples differed, though, where adults were assigned significantly lower importance, the adult sample assigned significantly lower importance to older adults aged 50 and above. Young people placed the highest importance on the severity of the prognosis of the individual who would receive treatment, and there are interaction effects here with the in terms of the age and carer aspects combined, which were not significant in adults but were in younger people. Right, let's have a look at some weights. The most important, I'm not going to go through all the variables because it's quite a lot of the other variables. There's not a lot of departure from the reference case. To see a departure of more than, say, 10% in most of the other variables, I think would be, that doesn't happen very often from my reading of the data. I'm looking at Elizabeth for confirmation, but in a sense the most interesting variable anyway in terms of the nature of the project is the age variable. So you can see that roughly in the middle there, that's our reference case where which sits at, for both adults and young people, sits on the value 1 for our weights, which is what's on the vertical axis there. So the age group 30 to 49 is our reference case for each of the samples. So for adults, on average, you'll see that mean weights are less than 1, which means that group, the reference group, in a sense, is deemed, according to these data, as the most important, because everything else is below that value of 1. For young people, you see more variation going from above 1 down to below 1. So the mean weight is greater than 1 for all the younger age groups compared to themselves and adults. And for both groups, the older are, not a very nice word, but deprioritized relative to the younger groups, which is, in a sense, is consistent with that variance hypothesis, I suppose. But observe very large confidence intervals, especially in the young person sample. These are just some post discrete choice experiment question responses where people were asked to indicate just one response to the question of what it was they were thinking about when looking at that particular factor. So here we're thinking about age. And you can see it's interesting, given what Marcus was talking about, that these are the two most common ones that have been highlighted, but the one at the bottom is more about is more of a kind of an egalitarian sort of equity-based argument, as you said, that in a sense there should be no discrimination. But the second most popular is older people already had a fair innings. So that's that again going back to that fair innings argument. So there's a diversity of opinion in the two most common reasons cited there. So these are the results for education. So you can see it doesn't look particularly active, but particularly for, like, well, let's just say for adults, there's more weight on being more able to participate in education now or in the future. For the young people, there's no statistically significant difference placed on participation in education at the aggregate level. And these are our more normative sort of education reasons when asked what people were thinking about with respect to that particular attribute. And again, you can see there the most common reasons. Second one down, better job opportunities for the patient in the future, ability to get work, access. I'm not sure it says to better things related to employment, no doubt. And then the one near the bottom there, future positive impacts and contribution to society. So it just backs up with what we found in the more quantitative data. This is the improvement to carers' lives weights. So it's kind of, I think we're still struggling to interpret this one. So I've labelled it as an unexpected result. So adults allocate weight of less than 1 when there's no impact on carers' lives, whilst young people give weight greater than 1 for that scenario. So I think it'd be good to have a discussion about how we would unpack that result. So just in summary, I think as expected, we're seeing larger health gains preferred. Gains to children were preferred over those for older groups. The fair innings concept seems to hold. There are, from my eyeballing of the data, there are magnitudes sort of 2 to 3-fold between the lowest and the highest weighted. It's interesting how comfortable people might feel about that. They are very much at the extremes of the age groups that we've used as our classifications. The willingness to trade off health gains for non-health benefits in education and to the lives of carers could indicate a social value attached to these spillovers beyond direct health benefits to the individual themselves that's receiving treatment, which again goes back to that last point perhaps that was made in the previous session. We need to look more at the interactions. So maybe Andrew would like to come up with a couple more scenarios. Anyway, thanks very much.
Any questions?
Sorry, I feel like I'm talking too much, but it's just quite interesting. I was interested, so I am interested in the fair innings thing, and I was wondering have you or are you planning to look at the responses from the adults to split them at all? Because I'm wondering whether the people who least value the older people are the older people themselves. So I would just be interested in whether if you split your adult group by under and over 50s, you get, that might be more what's explaining that, rather than it being a standard preference across all adults. And I suppose following on from that, are you going to do any latent class analysis with these data? That's probably for Elizabeth Roy.
That's right, so that's why I was about to give a microphone. I mean, on the first question, I think we would want to split the data. I mean, in a sense, you're talking about splitting by the characteristics of the respondents as such.
Yes.
And yes, we need to do much more, I think, in that respect generally, but that's a really good steer, I would say. Now, Elizabeth, how much do you know about latent class analysis?
She knows lots.
Well, I just wanted to answer the first part as well. Yes, I agree, it'll be interesting to sort of split and take a look. But at least from the results that we were seeing, though, people tended to favour their selves more. So then we might not see what you're looking at, but we don't know. Let's split it and see. Latent class, what would you be looking for in particular? I mean, I can do latent class, but I'm just wondering what kind of heterogeneity are we looking for?
I suppose I was wondering about whether it was the age of the respondents that was driving the...
Yeah, okay. Yeah, I think here the issue would be more like a reference, like they're using their age as a reference, and that's driving their choices, and that wouldn't be picked up in a latent class model. So I'm not quite sure if we want to do that. It will make this far more complicated. I could definitely go down that rabbit hole, but I just, yeah.
No, probably just by the respondent age, I think would just be...
Yeah, by respondent age, yeah, that would be good, actually, yeah. Okay, yeah, thank you.
Cam, I'm not sure if I understood that the slide about the carers, but it did make me think about the interviews we did with young people, and I didn't get to this, but some young people said they prefer to have a sick kid, they prefer to be sick themselves and their parents, because they, from a safety perspective, and feeling, yeah, they'd rather have a sick kid was sort of the expression they would say, that the parent wouldn't be able to work and they would need to take care of them, and that was preferable. I don't know if that actually relates to the slide you put up about that.
I think it does. It's part of the story. And I think what's come out in your session and a couple of the other sessions leading up to this one is that we make a lot of assumptions about what the preferences of young people and children might be, and the more qualitative work has helped with that unpacking, I think, in the way that you've just illustrated. And I think if we can somehow, now as part of the so what is not just about how we might use those results in deliberative processes, but it's about how do we relate the different work packages together, and that's a really important point.
I mean, the situations. Thanks, Ken. The situations where we've seen people that are looking at that carer question are both the young and the elderly. So we've seen it, and it's been considered in relation to dementia, for example, and the carer needs for people with dementia, which is obviously the elder spectrum. And then in the younger age, where it's been, for example, I can remember that was one of the cases with the meningococcal vaccine, the B vaccine. There was an argument that one of the things you avoided was these carer costs associated with the disease. But it's been argued in a whole range of other young children as well.
I think it was at those, in terms of the interactions, that's where most of the action was, at the two extremes of the age distribution.
Thanks, Cam. I think the results of the adult DC seems to show that the weight placed on healthcare was highest in early adulthood rather than in childhood or sort of later adulthood. And that's actually consistent with the results from various revealed preference studies, because we did, it was quite a crude sort of literature review of the evidence from the revealed preference literature. There wasn't much in there, mainly sort of in the transport context. And that seemed to show an inverted U-shaped relationship between age and value you place on healthcare, which is consistent with your adult results. And also one of Aki Shire's studies, where she did a person trade-off study, and then she followed it up with a qualitative research study, a think aloud study, but she and the other researchers involved in that study asked respondents to sort of explain their thinking behind their responses, and so some of the outputs from that research was really quite interesting. And people were explaining their preferences in terms of early adulthood being a period of life where you have most responsibilities, you have most greatest productivity potential. So I wonder whether we actually need a qualitative research study, or more of a mixed methods research study that tries to unpack what's driving some of these preference structures.
No, I agree. It does, I'm thinking about time, but that question leads us nicely into the next presentation, doesn't it?